So my name is Tony Urbanek. I'm an oral and maxillofacial surgeon here in Nashville, Tennessee. Been practicing for quite some time. But let's just talk about the problem itself. I have a lot of experience with TMD. So here's the problem, ladies and gentlemen. Everybody knows nothing works when treating TMD. Everybody thinks TMD is a complicated disease. Everybody thinks you have to be a specialist to treat TMD. Half the dentists prescribe a night guard for TMD and hope the patient doesn't return. And the other half put their fingers in their ears when they hear the word TMD or TMJ. Dental schools teach that TMD is a complicated disease, so they don't teach it at all. Dentists don't read the basic science literature about joints and chronic inflammation. The TMJ is a complicated name, gangliomo-arthrodial joint, so that justifies calling it a complicated problem. And there also are more than a few so-called TMD gurus who use smoke and mirrors to treat the disease. That's the problem that I faced my entire 50-year career wrestling with this disease we call TMD. So here's a warning. The information in this presentation will have a disruptive effect on the status quo. And a spoiler alert, applying this information in this presentation will initiate a new paradigm for treating the problem. So this is what you're going to learn in the next 50 minutes or so. Who is Tony Urbanek and why does he think so much, knows so much about treating TMD? The real definition of TMD, not the smoke and mirrors nonsense. All of the common symptoms of TMD, there are many more than you think. The prevalence of TMD, it is much more common than you think. The three causes of TMD, bruxism is not the only cause, there are two more. The common denominator of all the TMD symptoms, cure the common denominator and you will cure the disease. What the orthopedic surgeons know about TMD and the dentists don't, how to diagnose TMD easily, accurately, and predictably, and how to make the treatment of TMD a successful part of every dentist practice. So first, let me just start out giving you the answer to that first question. So I went to dental school at Indiana. I finished a year early. I finished in 3 years, but they wouldn't let me leave. So I spent the last 10 months of my dental school actually getting a master's degree in cell biology and anatomy. From that point, I came to Vanderbilt. Vanderbilt had offered me a very special program, which was internship and residency in oral and maxillofacial surgery, medical degree, PhD. And along the way, I arranged to get a fellowship with the NIH, NIDCR in facial growth and development, and spent the next 6 years or so working that project. Got my medical degree, did my residency, and finished all the academics on the PhD except for the thesis, but I had this grant from the NIH on facial growth and development. And what that grant was all about was I attempted to see if we could do facial reconstruction on animal models and making those animal models using intrauterine fetal surgery and a laser. This was 1978. Quite a significant title, but very short version in 1978 using the very first laser available in Tennessee, an old CO2 laser on loan from the Air Force. I actually proved that you could create animal models in the rabbit with reproducible facial defects. Intrauterine fetal surgery, zap them with a laser, come out with a facial defect. And when I presented all this material to my PhD advisor, I was told I had to have a thesis and produce a thesis and write up a thesis that was traditional research. Traditional research. I thought I was going to be a professor, but when I was told that I had to do traditional research, I told that professor that using tradition and research in the same sentence was an oxymoron, with the emphasis on the word moron, and I walked out, and that was the end of my PhD, and I decided to come out in private practice. So that's why I've been practicing for 50 years in Nashville, Tennessee. Now, let's get to the topic. What is TMD? The answer is it's a disparate array of confusing symptoms, a disparate array of confusing symptoms. You're going to see this slide a few more times in the presentation, but what are these symptoms? These are the well-accepted, well-documented symptoms of TMD: frequent and or recurrent headaches, earaches, neck pain, jaw pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, vertigo, dizziness. There's a little distinction between those two, actually, but they're similar: vertigo and dizziness. Upper shoulder and arm pain, arm, hand, finger tingling and numbness. I bet nobody ever heard about that. And various types of jaw locking. So those are the symptoms of TMD. There are a few more, actually, but those are the most common ones. What is the incidence of TMD? Well, if you read the literature going back, I don't know, 50 years or so, what country you're reading from, et cetera, you're going to read that the incidence of TMD is, first of all, it's primarily females. It's 45% females, actually, but the incidence in those articles really is 15 and 30%. But when you add all of the symptoms, which are misdiagnosed, like migraine headaches, Meniere's disease, a boatload of earaches that are constantly misdiagnosed out of the walk-in clinics, it really jumps to around 45% of females suffer from symptoms of TMD between the ages of 13 and 75. If you do the numbers on that, that's 76 million females in the United States suffer from symptoms of TMD. It's primarily, the next question you may have, I have the answer. Why is TMD almost exclusively a female disease? The answer has been in the literature for over 50 years. The answer is estrogen exacerbates inflammation. Estrogen exacerbates inflammation. And here's a reference that anybody wants to look it up, but there are many others. Estrogen exacerbates inflammation. So it's about 90% females, 10% males. 45% of the females in the United States of America have those symptoms. Donovan mentioned as we prepared for this little presentation that there are many hygienists that are going to be on the call, and I can promise you that there are 10 hygienists on the call. Half of you have TMD symptoms. So I won't bore you with a lot of anatomy, but we need to go over the basics for not everybody on the call may be familiar with the anatomy of the joint. Very simple. You got a ball in your socket, and in between the ball and the socket is a little cushion. We call it a disc or meniscus. The main thing you need to know about this joint is it has two anatomical motions. The first half is a rotation. First half between 0 and 25 millimeters roughly is a rotation around that glenoid fossa, around the socket. The last half of opening between 25 and 50 millimeters roughly is a translation. Translation meaning moving the ball down this eminence here. This is the temporal bone. That's the temporal eminence. And as the first rotation starts to do a translation, the condyle moves along with the meniscus. This is important. It kind of drags the meniscus with it as it goes down to open the jaw widely. Now, as these motions go on and under pressure or dysfunction, you can get damage to the joint itself in these particular areas of the bone, in this case, bone of the condyle, and the cartilage of the meniscus. And then too much has really been focused on about this thing called the dislocation of the disc. So, but we need to define that so we know what we're talking about. So this is the condylar head in the glenoid fossa, a dislocated disc that is in front of the condylar head. And when the mandible, it rotates okay in the first 25 millimeters, but when it starts to translate down the temporal bone, then it pushes the disc in front of it, and then finally the disc will click back. Usually that's when a patient will hear a much louder pop and usually some pain associated with this disc clicking or popping back. The clicking started years before it started doing this. The 15, 14, 13-year-old girls who have this problem, and it's almost a pandemic with 15-year-old girls. That's not just my opinion. I've been told that by many other oral surgeons. The first thing you hear is just that click, 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 click. And then when that's ignored long enough and not treated, then you get into the popping. And when that's ignored long enough, this is what happens. You go down, you start doing that translation, and it doesn't click back. It just doesn't come back, and that's what we call a closed lock. The closed lock, you only open halfway or so. I've seen it as few millimeters as like 12, 15 millimeters, but you're not going to push past that meniscus. So that is what we call a closed lock, and that's what the hoopla is about disc dislocation. All right, so what are the accepted causes of TMD? Well, there are actually three causes of damage to the temporomandibular joint, and I hope you can follow me along nicely on this because it is important to understand. We all know about bruxism, and pretty much everybody, patient and doctor and dentist alike, knows about bruxism and thinks that bruxism is the only cause, which it's not. We have acute trauma here in Middle Tennessee, in Nashville and Williamson County, where I'm from. Williamson County is just 10 miles south of Nashville. We have a lot of bar fights and 4x4s off the pickup truck. That's acute trauma. And for the females, it is almost exclusively, as I see, motor vehicle accidents, and whiplash is one of the primary acute traumatic incidents to the temporomandibular joint. And if it isn't easily understood, what happens is when you get that whiplash, you get that smash in the back of your car, your neck snaps back. Well, along with that neck snapping back, your mandible is going to snap open way beyond its ability to do it nicely, and you can stretch and damage the meniscus, at which point then you will end up with traumatic injury to the inside of that temporomandibular joint. And then the third one is what is commonly called functional malocclusion. As an oral and maxillofacial surgeon treating, spent most of my life in the operating room, by the way. I spent the minority of my life taking out wisdom teeth and dental implants. I did a lot of that, but most of my time was spent in the operating room doing orthognathic surgery, microneural surgery, reconstructing nerves, cleft palate surgery, trauma reconstruction, cancer reconstruction. And as that kind of surgeon, I always thought that a functional malocclusion was one of those patients that you could see the prognathysm from across the street, or they had a big old class 2 that needed their mandible forward, or they had a big old open bite. Well, I learned as I proceeded with treating TMD, I learned that actually functional malocclusion is best defined as any and all type of centric occlusion and centriculation discrepancies. Some people can have a relatively small CO-CR discrepancy, which overloads the joint. And when that happens, you do nothing but damage the joint. And damage to the joint, creates inflammation within the joint. So what all these three things have in common, what they all have in common is they cause damage and inflammation, which the body's response to damage. Inflammation, by definition, should be called the body's response to damage. So all the known causes of TMD create inflammation within the temporomandibular joint. How do you solve the puzzle? Well, as I said, the rest of my story started about 14 years ago. For the first 36 years of my career, I did orthognathic surgery and 2,000 temporomandibular joint cases, half of them through an arthroscope and half of them open joint surgery. I have done every kind of open joint temporomandibular joint surgery and every kind of closed joint through an arthroscope temporomandibular joint surgery that exists, over 2,000 cases. Well, 14 years ago, I decided that surgery was not going to be the answer. Literally a third of my patients would be back within a year with the same symptoms. And I spent a weekend thinking about this, and I walked in on a Monday morning and I told my staff, we are not going to be doing any more TMJ surgery. I could not look a patient in the eye and tell them I was going to fix them with my surgery, whatever kind of surgery I decided was appropriate, knowing that a third of the time the patients would be back with the same symptoms within a year. That was 14 years ago. At the same time, because of that broad background that I explained at the beginning of the presentation, the broad background, including a really good research stint with the NIH NIDCR as a fellow, I decided to see if I could take a lick at this thing called TMD that everybody knows nothing works. So I decided to do a little research project, start with the research itself, and my patients actually gave me the key. If you have a problem in medicine, where do you research start? You start with the patient itself. So what I did was I had a lot of people in line who wanted to see me. So I came in and told my staff, I'm going to see these patients, but just for a consultation. And they would come in and I'd sit them down and I'd say, tell me all about it. Again, most of them are females, almost all of them were at that time. Tell me all about it. What makes it better? What makes it worse? What does your husband think about it? What phase of the moon is it? Does the dog bark when it hurts? And they said all kind of things. And I'd sit there for 30, 45 minutes taking it all in. A lot of things I'd heard, but I heard something that I had never heard before. About the first 24 ladies, 12 of them said, if I take my pencil eraser, my finger, my tongue, or a piece of cloth and gently put it between my front teeth, it feels better. I heard that a dozen times and I said, I wonder what would happen if I went back into my little lab where I made orthognathic splints when I did orthognathic surgery, and I made a device that the patient could speak with. I decided what would happen. So I went back and I designed something that they could speak with because I knew I would want them to wear it 24/7 for a while. And with my experience doing a lot of cleft palate cases, I knew what it took to put something in the mouth that they could use and speak with. So I made a device and I gave it to the first woman and I said, put this in your mouth, keep it in 24/7, except when you eat. Obviously, if you have something between your front teeth, which separates the back teeth, you're not going to be able to chew it. So chew with it. So you take it out of your mouth when you eat. And I said, come back in 3 weeks. And I walked in the room in 3 weeks, and this woman looked up at me who had the usual history of 20 years of headache, earache, jaw pain, neck pain. And she said, thanks, doc, my pain is gone. That is where it started. I did about roughly about 20 more cases with pretty much the same results. Everybody came back better. Not everybody came back at 3 weeks and said all their symptoms were gone, but we now know what the average is. The average is 70%. But every one of those ladies I gave it to for the first 20 times, um, they they got better. The first woman looked at me. She looked at me and she said, you know, didn't you expect this to happen? Because I took a step backward the first time she looked at me and said, it's my pain's gone. Well, after 20 cases, I realized that I had no idea how this works. I truly didn't. So I had to go back to the books and figure it out. So this is actually not one of those women in the first 20 cases. This is a lady who came in to see me about 4 or 5 years ago. She had a little blue fish on a string hanging around her neck. And actually, at that time, I knew exactly what that was. She had a blue fish on a string hanging around her neck, but I knew exactly what it was for. But I did my consultation. She went on to, go on to treatment. But before she left to go up front and get involved with getting back and getting impressions, et cetera, I said, by the way, I said, what is this thing around your neck? And she looked at me and she said verbatim, this is what I use to keep me sane. I didn't laugh at her, but I knew what it was and I knew what she meant, because these patients are not nuts. These patients are not crazy, although our physician colleagues like to call them crazy and the dentists are afraid to call them crazy, but they're not crazy. They're crazy with pain. I have so much empathy for these people. I have so much empathy for these women. It is just amazing. So we knew what that blue fish was all about. So what are the puzzle pieces here? What are the puzzle pieces? What we know, what I know I did at that time and couldn't figure out, didn't know, was we're separating the back teeth. That's all we're doing. We're separating the back teeth. So one of the things we know about the back teeth, the back teeth, posterior teeth, produce 90% of the loads on the temporomandibular joint. That's why you don't crack nuts with your front teeth. In fact, you can't crack nuts with your front teeth. The proprioceptors don't allow it. So you crack your nuts with the back teeth. The other thing we know, or that I knew, after doing 2,000 temporomandibular joint cases, well, part of doing an operation in an operating room is it is part of the standard operating procedure to take a piece of tissue from that surgical site and send it to the pathologist for a pathology report. So there were 2,000 pathology reports that I got to review, and I learned that 100% of the time on a temporomandibular joint case, the first line of the pathology report came back as chronic inflammation. 100% of the time. Either it said chronic inflammation or it described the cell types, the cellular types that described chronic inflammation. And then the third part is the part that I found most absolutely interesting. I've really did a lot of thought experiments about this 100% of tissue coming back at chronic inflammation and 90% of the lows on the joint from the posterior teeth. But then I recalled something that one of my orthopedic colleagues told me in Vanderbilt when I did my orthopedic rotation. He said, Tony, you need to learn about joint splinting. You need to know about joint splinting. And I said, what's joint splinting? And he said, well, he says, here's what joint splinting is. He says, if you have tennis elbow, you have too much damage to the lateral epicondyle because of repetitive motions, too much repetitive motions of the forearm. That's called tennis elbow. And the condylar head becomes inflamed. But what the condylar head does, it sends an autonomic nervous system signal, the sympathetic portion of the autonomic nervous system, a signal is sent to the brain stem. It says, I'm inflamed. And the brain stem, the lower part of the brain, takes that signal, says, oh my God, you're inflamed. I'm going to help you out. We want that part to heal. Don't move that elbow. Don't move the joint. And sends an autonomic signal back down, sympathetic portion, to the muscles that move the elbow. And when those muscles get the signal through the sympathetic portion to tighten up, to constrict, that muscle pulls on the periosteum where the nociceptors are. You know, we have to call them nociceptors because you got to speak in Latin to sound important. And but the nociceptors are in the periosteum. They're not in the muscle. Brings me to talk maybe a little bit about the myofascial pain dysfunction syndrome. I knew Danny Laskin, who actually wrote the first article about the myofascial pain dysfunction syndrome theory. But in any case, getting back to the tennis elbow, that is what tennis elbow is. The patients don't complain of pain of the lateral epicondyle. They complain of pain in the forearm going all the way into the wrist. And why do they complain of pain there? Because the muscle is stimulated to tighten up. And when the muscles tighten up, they pull on the periosteum. It stimulates the nociceptors. And when they are stimulated, it gets back to the brain and received as pain. So if you follow me along, actually, tennis elbow and TMD are the same disease. I threw in a couple references if you want to read a little bit. There are many references about this, about the sympathetic nervous system and its relationship with osteoarthritis or inflammation of a joint, and the sympathetic how the sympathetic nervous system actually has a significant part to play in creating symptoms. And I have another one, sympathetic actions on skeletal muscle. So I want you to, I don't want you to think I'm blowing smoke here. I'm not blowing smoke. So here again, regarding the temporomandibular joint is joint splinting. When you have damage, how do you damage a joint? We've been through that. You have chronic inflammation because of bruxism, too much motion over a long period of time. That's what bruxism is. Acute trauma or functional malocclusion. The chronic inflammation sends a signal to the brainstem, says, I'm inflamed. The brainstem gets that signal, sends it back down the cranial nerves, and says, don't move the jaw, tighten up. And the muscles then that move the jaw will be stimulated to tighten up. And where they tighten up and where they attach to the bone, this is a critical to understand about diagnosing and treating these folks. They're going to point to the places where the muscles are attached to the bone. And they will tell you, oh, every morning, doc, right here, right on the side of my head, this is where it hurts, right where the temporalis inserts into the side of the skull. Or they'll point to the insertion of the mylohyoid underneath the chin, or the masseter muscles. Origin insertion makes no difference, or the lateral pterygoids, medial pterygoids. There are only a few, muscles of mastication. And when those muscles get the signal to get tight, they pull on the bone, stimulate the nociceptors in the periosteum, and it creates pain. Now, the very fascinating part is now, if you don't know how to get rid of the chronic inflammation, they keep sending signals to the brainstem. I'm inflamed. I'm inflamed. So it might take a month. It might take 10 years, but that brainstem is finally going to say, look, I told you, hold the jaw still. Now what I want you to do is hold the whole neck still. And when that happens, the neck starts to have significant amount of pain, and neck pain is the second most common symptom of TMD. So again, for the third time and final time, what is the phenomenon of joint splinting? You get an inflamed joint, in this case TMJ. The afferent transmission announces in the presence of inflammation to the central nervous system. The central nervous system sends an efferent transmission from the CNS to the muscles that activate the affected joint, in this case, temporomandibular joint, stimulate the muscles, not always the same muscles, not always the same morning. That's why these pains move around. First, the muscles of mastication develop trismus, pulls on the nociceptors, and you have TMD symptoms. When it goes on any longer, it stimulates the neck muscles to get tight. When it goes on beyond that, it stimulates the muscles of the upper shoulder girdle to get tight. And when that happens, not only do you get neck pains and upper shoulder pain, and you talk to these patients, they'll tell you about their upper back and shoulder pain and tightness, constant. But it also stimulates the scalene muscles, or we call them the strap muscles, if you remember, maybe from your gross anatomy. Remember, I'm an anatomist cell biologist by training. Those muscles get tight, and what do they squeeze? When they squeeze the brachial plexus. And the brachial plexus supplies sensation to the arm and forearm, and arm, hand, finger tingling and numbness develops. And when the inflammation goes away within the temporomandibular joint, the signals stop coming back down, the muscles loosen up, and the arm, hand, finger tingling and numbness goes away. Amazing. I did not know this when I first got into this. I don't think anybody knew it. First time it happened, the woman came in and she said, Doc, she says, thanks so much for making my headaches go away. But does this have anything to do with my arm, hand, and finger tingling and numbness? Because it went away too. And I just shook my head, rolled my eyes, and I said, I have no idea. Never heard of that before. It wasn't 6 months later that another lady comes in and she says, my arm, hand, finger tingling and numbness is so much better now. And then finally, it was not long after that, a third one come in, and I said, no, I got to look into this. And this is what I found. It's in the books. It's in Gray's Anatomy. If you know a little bit about anatomy and how the body works, it explains the whole thing. Arm, hand, finger tingling and numbness. I'm not the only person now. I believe there's another OMS up at the Cleveland Clinic who independently discovered it. I don't think she took it out of my work. I think she was just independently working with enough of these patients. She saw it also. All right, so it is not magic. Inflammation in the temporomandibular joint causes all of the symptoms. The device takes the load off the temporomandibular joint like a set of crutches takes the load off the knees. Decreasing the load on the TMJ decreases inflammation, just like a set of crutches. If you had a bad knee and declined surgery, you declined injections. Finally, the orthopedic surgeon says, I'll tell you what, you want to get rid of the pain, here's a set of crutches. You just stay on these crutches, I promise your pain will go away. And he would be absolutely correct 100% of the time. As the inflammation gradually decreases, the symptoms gradually decrease and go away. All right, so now I told you we're going to see this again. So we have now covered how you end up with all these disparate painful symptoms. of the masticatory functional area, the neck, the shoulder, arm, even the arm, hand, finger tingling and numbness. So what are we left with? We are left with headaches, we are left with earaches, we are left with tinnitus, subjective hearing loss, vertigo, and various types and degrees of jaw locking. And we're going to cover these next very rapidly, but very clearly. So when I started looking into this academically, the first thing I did is I brought out my Gray's Anatomy that I had not reviewed for a while. This is actually a diagram off of my personal 1954 edition of Gray's Anatomy, which was gifted to me by the chairman of the Department of Indiana School of Medicine, Department of Anatomy, when he found out I couldn't afford a Gray's Anatomy. I still have that book. So this is, let me get you oriented here. For me, I think I expect too much from too many people when I just phase through these anatomical diagrams. So let me orient you. This is the external auditory canal. This is the front of the face out here, the zygomatic arch, glenoid fossa, socket, external auditory canal. This is temporal bone here. And the first thing I want to point out on this diagram is the proximity to the glenoid fossa or socket of the temporomandibular joint to the external auditory canal. Now here on the lateral or outside of the canal, the bone is fairly thick. I can't show it to you on this diagram, but as you go down about 1 centimeter down this canal, which by the way does not go perpendicular. This canal does not go perpendicular into the temporal bone. It goes posterior anterior. So it actually travels at about 30 degrees anteriorly. But as it goes down about a centimeter, 8 to 10 millimeters, the bone gets very, very thick. Actually, very thin, paper thin, so that you can imagine that when you get inflammation filling this temporomandibular joint, you can get the exudate and or cells, but most likely exudate fluids that can penetrate this very, very thin layer of bone or periosteum, which stimulates that into the external auditory canal. And so when the walk-in clinic physician's assistants look in this ear and she says, I don't see any infection. And the patient says, no, I'm telling you, I have an earache. And the PA, who is not used to looking at many ears, says, I'm not certain about any infection here, because you're not going to see infection. What you see, if anything, is a little redness on the inside of the external auditory canal. The tympanic membrane will look perfect, but I can promise you that patient will walk out of the walk-in clinic with a prescription for antibiotic, for sure. I mean, we see that hundreds of times around here. So that is how you get earaches from inflammation within the temporomandibular joint. The second thing that I'd like to point out on this diagram that came to my attention immediately was this thing called the petrotympanic fissure. Well, what is the petrotympanic fissure? A fissure is a linear opening between two portions of bone, two different bones. It's a fissure. It's a potential opening, linear opening. This one's called a petrotympanic fissure, and it is right at the posterior part of the glenoid fossa. Well, as it works out, on some people, under some circumstances, that fissure allows chronic inflammatory fluids, exudates, up that fissure into the middle ear. Now, what we're looking at here is coming from the 180-degree opposite of that prior diagram. This is you're standing inside the middle ear. This is the tympanic membrane, a little enlarged, but tympanic membrane. Here is the opening of the petrotympanic fissure. You see, actually, we'll talk about chordotympany in just a minute, but it is an opening, a potential opening. Here it's called the Glycerian fissure. Why? Because in 1680, that's 1680, in 1680, a very bright Swiss anatomist found and named this fissure, and it is also called the Glasserian fissure, Dr. Glasser, Johann Glasser, uh, and it is also called the petrotympanic fissure. And that allows inflammatory fluids that can do all kind of harm if it's only the change in pH. We all know that inflammation has an extremely low pH. I do not know why inflammatory fluids will actually make changes, but it can easily be just change in pH will damage the hearing mechanism. All these little structures in here, the vestibular mechanism, the hearing mechanism will get damaged, and patients will complain of tinnitus, um, subjective hearing loss, like there's water in their ear, and vertigo. Um, it also will explain why some patients will come to your office or come to your attention and they will complain of burning tongue because the porta tympani, as which I'm sure it was drilled into you. This is one of the things I saw anatomically will drilled into all the dental students. The porta tympani coming off the facial nerve comes down through the Glasserian fissure, petrotympanic fissure, and supplies taste to the tongue. And if people complain of burning tongue, this is what happens. This inflammatory area gets inflamed and it causes burning tongue. And you can see the proximity of actually one wall of the Glasserian fissure is actually one wall of the eustachian tubes, the fullness in the ears. So tinnitus, subjective hearing loss, fullness in the ears, and vertigo can easily be explained by inflammatory fluids getting pushed up the Glasserian fissure into the middle ear, the inside of the temporal bone. So we've covered all of these now except various types and degrees of jaw locking. So under the influence of chronic inflammation, synovial fluid becomes sticky and loses its lubricating qualities. That's in the literature for forever. A lot of studies have been done on synovial fluid in animals and in humans. But what we know is synovial fluid is a lubricating fluid, much finer than any kind of oil. But under the influence of chronic inflammation, it becomes sticky. So now when that condyle comes down the temporal eminence, it literally, under the influence of sticky synovial fluid, will actually push that meniscus in front of it because it's stuck to it. It's sticky. It's glue-like. That meniscus does not get pulled forward, and that's been consistent thought for 50 years about how it gets dislocated. Now it gets dislocated because it gets pushed down there because the synovial fluid is now sticky. And imagine, and it actually blew my mind away when I found that over a period of time, when you gave that joint enough time to recover by just unloading the joint, allowing the inflammation to die down, that the synovial fluid recovered its a proper fluid values, so it wouldn't be sticky anymore. It would be more like a glue, more like an oil, and that meniscus would come forward naturally. Most of the time, I can't quote a number here for you, but I can say over 80% of the time, once you unload a joint, allow the inflammation to go away, you allow the synovial fluid to take on its proper formation to be a lubricant, that meniscus will come forward by itself. And you turn a closed lock into a full opening. All right, so let's finish up here. So it's not magic. Inflammation in the TMJ causes all the symptoms. The device, which we'll talk on briefly, the device takes the load off the TMJ like a set of crutches takes the load off the knee. Decreasing the load on the TMJ decreases the inflammation. As the inflammation gradually decreases, the symptoms gradually diminish and go away. Now, how do you diagnose TMD? This is important, and you do not have to be a specialist to treat this problem. That's what I found. The silliest thing that ADA did in the past few years is try to make, and they did make, orofacial pain a specialty. I don't believe it. I don't agree with it. But here's how you diagnose TMD. You look for these symptoms. Symptoms, as you should know, are nothing more than red flags in front of your face. Just a red flag. You don't make a diagnosis off a red flag, but you do this. You have some red flags accumulated, and then you do this. Why? This is the second time this has happened when I have. All right. Huh. All right. Well, this is what you do. Apologize for that. That shouldn't have happened. So what you do is you stand behind the patient. Hopefully all can see me. Stand behind or beside the patient. Have them open widely. Have them close their and put your finger in the glenoid fossa firmly and have them close rapidly just once. If it hurts, they have TMD. If it hurts, they have inflammation in the joint. If they have inflammation in the joint and they have some of those symptoms, they have TMD. It's that simple. So that's basically what you need to know about the problem. Let me see here. So the exam outcome, if it hurts and the patient has one or more of the symptoms, they've got TMD. You don't need machines. You don't need stethoscopes. All you need is a couple fingers and understand what you're looking for. You're looking for inflammation within the joint. And of course, the patient has to have symptoms. Again, I'll show you again, but it's really simple. I'm sorry that the video didn't show up. Have them open widely, put your fingers firmly in the glenoid fossa, and have them close rapidly. If they go, ouch, you made your diagnosis. The joint is inflamed. You have TMD. So the protocol for using a posterior disc occluding device is important. It's a device and protocol. The device is just a tool. The device is just a tool that the patient can talk with. They got to wear it long enough. You don't have the patient just wear it anytime they want. That's not going to work. You have to wear it appropriately. We have found the proper protocol is 24/7, 24 hours a day, 7 days a week for the first 2 months. Let me bring out right now before I forget, somebody's going to ask, maybe you already asked, if you disocclude posterior teeth in an adult, you will not get super eruption in an adult in 2 months. Children, adolescents, you got to be careful. And then nighttime indefinitely, nighttime only indefinitely. What we have found that 15% of the patients find they need to wear it more often. Ladies here in Tennessee come in and tell me, I figured out when I'm in traffic, I need to put it in. Or the other one we hear frequently is, I figured out when I'm sitting on a computer, I need to put it in. But 15% of the patients find they need to wear more during the day, but never 24/7 again. 24/7 only for the first 2 months. And then nighttime only the rest of your life. 85% nighttime only. That's all they got to do. So here's the device itself. This is the one. This is the original iteration. Had a ball clasp on it. All I was doing is separating teeth, just like the lady said. If I put my finger between my front teeth, it feels better. This was again, the original iteration. You don't direct the mandible anywhere. It's a flat plane. You just let it slide wherever it wants to slide. This is the newest iteration because it's hard to work with the ball clasp. They break. They have to be bent and replaced all the time. And we figured out how to do this CAD CAM on a computer and 3D print it. And we keep retention with these little covers or whatever you want to call them over the premolars. It's all patented. And this is what it looks like from the superior position. Good retention, flat plane, doesn't take them anywhere. You do have to know how to use this correctly. It applies to all classes of occlusion, class 1, class 2, class 3. The device has to be modified just a little bit, but that's it. Now, I want to spend just a moment talking about other devices, making sure that you understand that this is a device and protocol. There are other devices that separate the back teeth, and they have some value. There's no doubt. I'm not trying to say they don't have value. The one you know most is the NTI, but you can't speak with it in your mouth. You can't talk with it in your mouth. Um, you It has some inherent problems of its own. I won't go into that, but the big problem is you can't wear it 24/7. And you have to start out 24/7 to allow enough time and consistency to allow that inflammation to start dying down within the temporomandibular joint. There's a thing called a quick splint, which is kind of a boil and bite thing that the company that does that even promotes it only as an emergency. It's not very stable. It's easy to come out. Again, you can't talk with it. They call it an emergency device, and it has some value. if you just do it temporarily. And the third, I think we'll call the COIS, which is designed for and used for diagnosis and getting somebody back into centric relation. But that's an example of the COIS device. We have an independent statistical study, which was actually formulated by Middle Tennessee State University. We had 3,000 successful patients. As independent, I gave them 3,000 names. I gave them 3,000 patients. I said, you design the study, you ask the questions. It was a retrospective study on 3,000 people, and I'll be happy to send this study to anybody that's under my email and can send me an email. The other thing I want to bring to your attention is this is a huge, huge benefit to practices. This is a big problem. 45% of females have this problem. And so I put my mind to it. How do you get the word out? How do you market this to the public? Well, you don't market it to the public. You market it primarily to the doctors who misdiagnose it, mistreat it, misdirect it all the time. Our state is full of physicians. Remember, I have one of those degrees. I got the union card. And what we see is TMD is being misdiagnosed all the time as other types of headaches, migraine headaches. In fact, due to TV, everything is called a migraine headache now. But here's what we figured out because of the proprietary, meaning we figured it out independently. We have 900 referral sources of all kinds, dentists, physicians, walk-in clinics, nurse practitioners, chiropractors, neurologists. But here's how you do it. At the consultation appointment, patients provide the receptionist with the names of all previous providers that they can. Their dentist, their PCP, the neurologists, the walk-in clinics. Remember, most of these patients have been abused by the system. They have been having these symptoms for 10, 20, 30 years. It is not unusual at all. In fact, most of the patients we see have had these symptoms for 20 years or more. Physical therapist, chiropractor, oral surgeon, pedodontist, orthodontist, ENT, etc., that they have seen for their TMD symptoms or any other health problems they have. At every subsequent appointment, a letter is sent to each of the doctors on that list announcing their patient of record. Now, they're getting a letter on a patient of record with the TMD diagnosis, the symptoms that patient came in with, and the percent decrease of the symptoms noted by the patient's subjective assessment, which means we literally ask each patient at every post-insertion appointment, what percentage of your original symptoms are decreased or gone? What percentage, on average, are decreased and gone? They give us one number, and that number is sent to all of those doctors. And within a short period of time, you start getting referrals from all of those doctors.